Thank you very much, President. It's very kind of you. And thank you very much for inviting, but I'm sure I speak on both myself and Bill's behalf, and thank you very much for asking us to contribute to the UCD Health Affairs Lecture Series. As you indicated, myself and Bill have been working together for many years now. I think about 19 years in total since I did my thesis in the Mater Hospital. And we've continued to collaborate on a number of studies and efforts over the years. And I must say it's my delight to be in a position now that I can engage with patients and help the scientific efforts, particularly in contributing patients, biological specimens, blood, serum samples and tissue for our ongoing research. In relation to prostate cancer in Ireland, I suppose I have a number of concerns that I wanted to highlight on this slide, just to sort of paint the picture of some of the concerns or issues that we have to address in Ireland over the next number of years. And prostate cancer care in Ireland faces a number of challenges. We've certainly seen the incidence of prostate cancer continues to rise, largely due to, I suppose, serum PSA testing and primary care, but also an ageing population. And unfortunately, our population is going to continue to age, and therefore we're going to see more disease in the coming years. Also concerned about primary care testing. I suppose as urologists, we've given up prostate cancer testing or PSA testing to our GP colleagues in primary care. And unfortunately, for many years, this was with very little guidance. I don't think anybody understood the role of the test and how best to use it. And therefore, unfortunately, for many years, I think it was inappropriately used. And we do have some guidance now from the NCCP. But personally, I think that looking for prostate cancer in our population is something that urologists should be guiding on and possibly taking back from primary care. We also are unaware at the moment, because we just don't have the data around standards and variation in prostate cancer care around the country, not only within the country, but also from hospital to hospital, from urologist to urologist and so on. We just don't have any data as to what sort of quality of care is being offered around the country. We must think as well that the therapies associated with prostate cancer treatment all contain serious side effects that have potentially detrimental effects on our patients' physical and mental health. We also don't know what the outcomes are in terms of oncological outcomes across Ireland. So just to focus on the orange bar towards the bottom, this is a slide from the National Cancer Registry in relation to prostate cancer incidence and projected incidence over the next 15 to 20 years. And what we would expect to see is there could be apologies behind me here, but this figure here is a 97% increase in prostate cancer in our population over the next 15 years. So bearing that in mind with our aging population, we're going to see a large increase in prostate cancer across the country. Just to sort of highlight my concerns around prostate cancer testing and a population-based approach, this is a publication from European Urology about 3 years ago by our highly respected Swedish prostate cancer testing cohort. And if you look at the bottom line, that they surmise that only an organised prostate cancer population testing or screening program will yield significant improvements in terms of prostate cancer morbidity and mortality. Currently in Ireland, we operate on an opportunistic screening. So essentially, if someone decides to go along to see their GP may or may not test them for their PSA test. It's as it's as uncoordinated as that. People who can't afford to go to their GP won't get tested. People who don't have any other medical problems don't need to go to see their GP, won't get tested, whereas those who might have diabetes, high cholesterol levels, GPs and GP nurses will throw in a PSA test, and lo and behold, they find themselves in our rapid access clinics. So we don't have any sort of a sensible approach to population-based testing. And this, looking just at this series here, these authors said that an organised screening program based on a lot of the European randomized control data, showed a 42% reduction in prostate cancer mortality, and that was over about 18 years of follow-up, versus an opportunistic screening program at best will show about 12% reduction in mortality. Opportunistic screening, which we currently run in Ireland, essentially results in little or no survival advantage, more overdiagnosis, and probably no benefit to our patients or our population as a whole, whereas an organised population screening program will have much more significant improvements. And we have put a proposal in to both HipCore and the NCCP advocating a population-based prostate cancer testing program. So my concerns are that we see a perfect storm sort of brewing. We have our prostate cancer, our commonest solid tumour in men. We have an ageing population. We have an increasing incidence of prostate cancer across the country. We don't have proper primary care testing or population-based testing. We have very limited healthcare resources for new initiatives to commence. And we don't have any source of clinically meaningful data that we can source as a country so that we can make high-quality decisions about use of our resources on how best to look after our patients. Moving on from that, then we also have the unmet needs which have been highlighted of our patients with prostate cancer. Prostate cancer survivors make up about 1/3 of all cancer survivors in Ireland from the latest Irish Cancer Society data. And that's because a lot of those patients may not have had disease that may have impacted significantly on their life expectancy anyway. Survivors often suffer urinary, bowel dysfunction, sexual dysfunction and infertility. And psychosocial effects include anxiety, depression, a feeling of loss of masculinity, subsequent relationship and intimacy difficulties, and for those maybe that are self-employed and others, financial issues as well. There are little or no resources available within our healthcare service to help these patients, and therefore we must look at their unmet needs and propose ways of how to improve the care for our prostate cancer patients. So this brings us along to the area that we've sort of expanded and become interested in, which is health outcomes research. Health outcomes is a measure of the quality of our healthcare that we give our patients. The International Consortium for Health Outcomes defines it as the results of treatment that patients care most about. Health outcomes research is the generation and use of evidence to make healthcare decisions for healthcare providers and users. Essentially, it fosters improvement and adoption of best practice across the board and across the whole country and in every geographic location. I think it has never been more important that decisions on valuable resources within our healthcare system are based on high-quality clinical data and patient outcome data, so that we should be supporting treatments and investigations that see good clinical improvements, but also good patient outcomes. So we've aligned ourselves in all our efforts with ICHOM, which is the International Consortium for Healthcare Measurement based in Harvard. And their first publication was based on localized prostate cancer and was partly funded by our funders, Movember. So we use ICHOM data and measurements in all our registry data, so to ensure that we are aligned internationally with other registries for comparison purposes. Through our National Cancer Control Programme, we have made some inroads, and we have just recently produced updated GP referral guidelines to advise primary care as to when to refer patients in and so on who are suspected of having prostate cancer. And I've also been involved and chaired the diagnosis, staging and treatment of prostate cancer guidelines, which have been published through the National Cancer Control Programme as well. But I suppose our project with the most potential is the Irish Cancer Society and Movember funded Irish Prostate Cancer Outcomes Research Project called HipCore, which myself and a number of co-investigators have been running for the last 4 to 5 years right across Ireland. What HipCore essentially is a collaboration of a number of national programs, such as the National Cancer Registry, National Cancer Control Programme, to set up a prostate cancer registry right across Ireland. Essentially what we've done is we've started collecting data in 15 hospitals across the country, 8 of which are publicly funded hospitals, 7 of which work in the private system. So we're collecting data in both the public and private service, 15 hospitals, collecting approximately 80 to 85% of all men newly diagnosed with prostate cancer. The goals of the study are to set national standards for prostate cancer care in Irish hospitals and to collect high-quality clinical data, producing reports that will influence our decision makers to improve care for prostate cancer patients. We want to ensure that decisions about prostate cancer are transparent and based on high-quality data. And using this data, we can then carry out a variety of studies investigating issues that impact men with prostate cancer. And then using this data, and because we're being funded by Movember, who are establishing similar registries in other countries, we can compare the outcomes of Irish men with prostate cancer with those around the world and ensure that Irish men receive the highest standards of care. I'm just going to show you some of the data that we published in our 2018 report, which was our first data-driven annual report. So over the 2 years collecting data from 2016 and 2017, we were registering about 230 men per month into our national database. You can see here the age categories. So the average age of diagnosis of prostate cancer in Ireland in 2017 was approximately 65. Previous data had suggested it was more closer to 72. So certainly we're seeing a much younger cohort of men being diagnosed these days. Just an infographic, just showing roughly the green men are men under the age of 70 diagnosed with prostate cancer. So about 1/4 of all men are under the age of 60 when diagnosed. About 2/3 of all men are under the age of 70. And it's quite uncommon then to be diagnosing any men with prostate cancer over the age of 80. So it's no longer really considered a disease of older men. 50% of men who are under 65 are obviously would be working, holding down jobs and families, getting their kids through college, whatever it is. So obviously a diagnosis of prostate cancer and all that entails might have significant consequences for those younger men. We're also able to look at data both from the public and the private service. So looking at access and how patients access care, this interesting slide shows the lighter blue is the patients accessing through the public system, and the darker blue is the referral system through the private healthcare service. So across Ireland, what we're seeing is that about 2/3 of men are accessing care through the public service, despite the fact that we know that probably a good deal more have private health insurance. And this is probably a reflection on the success of the rapid access clinics in that a lot of patients with private insurance, due to the rapid, assessment and access to care within 4 weeks, would avail of the rapid access clinics supported by the NCCP. The age cutoff is generally under 70 for that group, so you will see that over 70s there is a slight rise in patients using their private health insurance. Because we had patient involvement in our steering group, patients wanted to see what was the delay, the access to care, what was the time frame that patients would be seen, get a biopsy and informed of their diagnosis. So this comparison just looks at the green line, which is private patients, versus the dark and the light blue, which is public patients under and over the age of 70, in other words, divided by their access to the rapid access clinics. And what we do see is that the average private patient would see a biopsy within about 4 to 5 weeks and be informed of their diagnosis within about 6 to 7 weeks. However, that was a good deal longer for public patients. But overall, when we're talking about prostate cancer, obviously we don't feel that these time differences are going to be clinically significant. We also broke down our data looking at the presence or absence of symptoms. So you can see there the under 65 group is to the left and over 80s then to the right. You can see that the vast majority of patients were presenting without any symptoms whatsoever. So what we're really seeing here is essentially prostate cancer screening is taking effect across Ireland in a rather chaotic or uncoordinated fashion. So the vast majority of patients don't have any symptoms, but you can see as men age, there's more and more men presenting with symptoms, certainly over 80 as well. Just to assess whether or not patients were presenting at the same stage of disease, whether they went public or private, one gross estimate of that would be to look at their PSA levels on referral. I think you can see roughly that the patients, whether you were private or whether you were accessing the rapid access clinics, your mean PSAs were essentially the same, and obviously a slightly higher PSA for men over the age of 70, which is exactly what we'd expect to see. So certainly it's nice to see that there isn't any discrepancy in the stage of disease when patients are being accessing care. There's a paper published by the Cancer Registry about 25 years ago, and they looked at the outcomes of patients accessing public and private care, and they said that the most significant finding was that the thing that determined how well you did in terms of prostate cancer was your health insurance would determine how well you did. So it looks like we've come a long way in providing better access to care for patients, whether they're public or private. Just to talk for a moment about low-grade prostate cancer as it presents a particular dilemma for us in urological practice. We all are well differentiated adenocarcinoma of the prostate, otherwise called Gleason 3+3 disease, is extremely common. We know it occurs in men from their early 40s and becomes virtually universal in men by the time they reach 80. It tends to run a very indolent course and by its nature does not metastasize. Therefore, reducing the detection of this Gleason 6 prostate cancer would significantly impact on reducing overdiagnosis and overtreatment, and low detection rates would be an indicator of a high-quality diagnostic regime. Many men, when diagnosed with low-grade prostate cancer, are currently placed on active surveillance protocols and have to return to clinics on a regular basis to great expense to our healthcare system for repeated visits, repeated MRI scans, repeated biopsies and morbidity related to those biopsies. So therefore, reducing the number of low-grade prostate cancer diagnoses would significantly help our healthcare system. This is just data from Albertson, just showing the 20-year expected survival rates for men with prostate cancer. So if you just look at the third level, the third bars, which is the Gleason Score 6, essentially at any age, a man is much more likely to diagnose or die from non-prostate cancer causes if he has Gleason 6 disease. So therefore, we try to limit and reduce the pickup rate if possible. So this is the Gleason scores detected in Irish men over the last, during the duration of our study. And you can see the Gleason 3+3 disease, unfortunately, is by far and away the most common prostate cancer detected in men. Only about a third of cancer would be falls into the Gleason 4+3 and above region. 2/3 of men are diagnosed with Gleason 3+3 or Gleason 3+4. And I suppose the natural history of these type of prostate cancers can be quite variable and slow growing. When we break that down by age, you can see that the younger men, less than 65, make up a vast majority of men diagnosed with low-grade disease. So a lot of these men have now been assigned to active surveillance protocols, and we find them clogging up our clinics, coming back for recurrent biopsies and recurrent MRI scans. And I suppose reassuringly what we can see is as men get older, I suppose due to the urologist's discretion and so on, we diagnose a lot less low-grade disease and a lot more high-grade disease. We also use something called a Capra score, which is a risk score that you can attach to any patient based on a whole range of different parameters. So in our database, we measure all these parameters on every patient in Ireland, and we're automatically able to give each patient a Capra score. And that score will then put the patient into a risk category. So obviously if somebody has a low risk category, you'd expect them to do very well. So this is the breakdown of Irish patients according to their Capra score. And what you can see is the vast majority of patients fall into the lower score ranges. So based on this, we would expect those patients to the left of the graph to do very well. So over time, by following these patients, we expect these patients to do very well in terms of their disease. And you would also hope that they would report favourable urinary and sexual function outcomes and quality of life outcomes as well, so that we can obviously tailor the treatment to the aggressiveness of their disease. We can also use this to look at quality of care. If patients in certain centres are having poor outcomes where you might expect them to do very well, certainly you could question the quality of care in those certain areas. We've used the Capra score to look simply at imaging. So obviously as somebody's Capra score goes up, they have more and more significant or aggressive prostate cancer. And therefore, by our guidelines, we should be imaging those patients more intensively with CT, MRI and bone scan. So I suppose it's nice to see that there's a nice pattern that if somebody's Capra score goes up nationally, we're imaging those patients more. But truly, if you followed our national guidelines, anybody with a Capra score greater than 7 should be getting a CT scan, and obviously a large number of patients aren't, whereas patients with lower Capra scores who don't need CT scans are perhaps inappropriately being imaged. So therefore, we can highlight these. This would be, I suppose, contradictory to our national guidelines. Similar bone scan imaging for patients with higher Capra scores. We can see a much more reliable picture of more patients being imaged with higher Capra scores. Interestingly then, we also looked at MRI imaging. So essentially all patients now diagnosed with prostate cancer get an MRI scan of their prostate at some stage. But it's when they get their MRI scan that's important. Ideally, if you get your MRI scan done before you have your prostate biopsy, you can then have a more targeted and a better prostate biopsy that's more likely to reveal prostate cancer and prevent further biopsies in the future. So ideally, we would do an MRI scan before a prostate biopsy. When we looked at the data here to see what about 1/3 of all our patients would get an MRI scan across the country before they get their biopsy. But when we broke that down into public and private, we found that you were 3 times more likely to get an MRI scan before your biopsy if you had private health insurance versus those who don't have private health insurance. So therefore, we need to do much, much better in being able to provide MRI scanning for our across the board in our public hospitals. I just want to talk to you for a moment then against a new initiative that we've begun in the Mater Hospital, just breaking away from HipCore for a moment, which is focused more on improving patient outcomes from their treatment. The Prosper Clinic is a clinic that we've developed in the Mater over the last 18 months, and it's been now established over the last 6 months, and it's been pioneered by our NCCP prostate nurse, Catherine McGarvey, and myself and Kieran O'Malley supporting this endeavour. So the Prosper Clinic is a multidisciplinary clinic designed to educate and support our patients throughout their prostate cancer journey. It consists of 3 components: a prehab or prehabilitation component before they undergo their treatment, rehabilitation afterwards, and a survivorship clinic focusing on achieving the best outcomes over time in a supportive environment. What it incorporates is we have exercise and pelvic floor physiotherapy for our patients, nursing component, nutrition and dietetics, clinical psychology, and patient advocacy in the form of cancer services. We also want, through this Prosper Clinic, to develop the medical, nursing and counselling expertise to assist men who have essentially complex problems in terms of pelvic floor dysfunction, psychosexual problems, psycho-oncological complications following their treatment for prostate cancer. And it also allows us to drive research forward by asking these patients to get involved, offering clinical data and biological samples collected for outcomes research. So the interventions we use through the Prosper Clinic, as I said, are exercise and pelvic floor rehabilitation. So we put our patients on our physical exercise program before their surgery and after their surgery, essentially prescribing them physical exercise. And we also use pelvic floor exercises to help them regain their urinary control after they've had their surgery. We also offer psychological support, which patients can avail of cognitive behavioural sessions, relaxation, counselling, decision support, couple counselling. But where we provide this Prosper Clinic is in a classroom-based session where we cohort the patients. And because we can't offer all of them psychological support, we teach them of the symptoms and signs that they can look out for themselves, sort of red flag symptoms that they can then highlight to us in confidence if they need to seek psychological care. And we also offer them nutrition and dietetics interventions as well, putting them on healthy diets and getting them to exercise. So as I said, the Prosper Clinic is a seamless pathway from prehab, rehab and survivorship. In the prehab clinic, they'll avail of physio, exercise, diet, psychological, but then after their surgery, the emphasis is more on urinary control, what we call penile rehabilitation, which is sexual function assistance, psychosocial support, and continuing the exercise and the diet effort. And then the survivorship component is more to do with peer-to-peer. It's men helping themselves, getting together in support groups, using a website, using possibly a blog or sort of email chat rooms where they can confidently, in confidence discuss some of their physical and mental health issues after their treatment. We believe that psychosocial therapy is a very important component. Suzanne Chambers from Australia has published papers that highlight that 60% of men diagnosed with prostate cancer suffer clinical anxiety, and up to 10% can suffer from clinical depression. And this is very often more commonly seen in younger men and also single men. A very small number can even go on to commit suicide, and we actually had 3 reported cases in the Mater Hospital over the last 5 years of men who committed suicide shortly after their diagnosis or their treatment. We don't have any funded services currently available to target or treat these men. So by screening all newly diagnosed men for psychological illness is recommended, and we encourage, as I said, men to highlight red flag symptoms when they're worried. So group sessions, discussions and social chat recommended to assist, and certainly from the nurses that tell me who operate the Prosper Clinic, it's the cup of tea after the education and the support that is most helpful for the patients when they actually get to open up. So we've developed a website to support the Prostate Clinic, and we're hoping to expand this and have this available for the survivorship component. We also work very closely, as I mentioned, through the Irish Cancer Society in Movember. They fund a program called True North, which is a global program where patients can log in to the True North website, and there are online modules that they can find out about urinary problems, sexual function problems, and how to access care and treatment. And we actually contribute data to the True North Global Registry. So through our efforts, we've been lucky enough to engage with patients. I've been lucky enough, I suppose, in the last number of years to witness the impact that patient engagement in PPI has brought to our projects. We've always had patient representation from Men Against Cancer. HipCore established a patient panel to advise the project in 2019, and we have 8 very active volunteers some of them are still going through treatment, who are able to advise the project and give a very personal approach to the project. Our future funding proposal for HipCore has involved patients right from its inception, and the Prostate Clinic steering group has a strong patient representation as well. I must say, as investigators, it's hugely rewarding, and to see things from a patient's perspective and how that can shape our projects has been hugely beneficial to our projects. I've seen the enormous contribution that patients make and how they volunteer their time and how it's not easy for them to do that. So just to conclude, just to bring you back to the start, I mentioned the potential crisis looming with the increase in diagnosis, our aging population, and the lack of services really to deal with these in our healthcare service. HipCore is trying to develop the tools to obtain the high quality clinical data to make decisions and drive research. We have built a strong collaboration with the Irish Cancer Society and the Movember Foundation, and looking forward to furthering that over the next number of years. We also want to see improved diagnostics to reduce overdiagnosis, and I know that Bill will be touching on some of these efforts in his talk. We also want to see the Prostate Clinic model, which we've built up in the Mater, rolled out nationally to support patients right across the country through our cancer centres, and achieve optimal outcomes for those that require radical therapy, and continue to engage patients in future research and service development.
So as David has identified, clinical decision making is really, really important, and we need to get this right. And there are obviously guidelines do recommend the use of decision support tools. The National Comprehensive Cancer Network and the NICE guidelines, recommend the use of nomograms in combination with patients in making these decisions. So working with David, we wanted to progress this work, and actually this is what patients want as well. So working closely with David and his PPI groups, patients have identified that they need more support around choosing appropriate therapies for them, because a number of them have regrets over the treatment choices that they have made based on some of the significant quality of life and side effects that David has alluded to as part of his presentation. So a number of years ago, we set out to identify the key clinical decision-making steps that are made by both the clinician and the patient, from determining the need for a biopsy, understanding if their disease is indolent or aggressive, which would then inform an appropriate treatment, as David said, active surveillance for those patients who have indolent disease, or if they have aggressive, is it organ confined, non-organ confined, which will inform the appropriate treatment of surgery, radiation therapy, or chemotherapy. So we identified these, and what I want to do is map some of the work that we've done in line with what David has said to this decision making pathway. And I want to start off with the question around the need for a biopsy, because as David was saying, if we could reduce the number of men that are actually even going to be diagnosed for prostate cancer, that would take a huge burden off our healthcare system and clogging up our system with men who really are probably well with low-grade disease. So a biopsy is the ultimate tool, gold standard for the diagnosis of prostate cancer. Again, David would be able to talk about this better, but it's basically the insertion of a needle up into the prostate, and it is associated with its own complications of urosepsis, prostatitis, discomfort, urinary retention, not something that we would need to have if we didn't need to have it. Now, there are a number of risk calculators out there that have been developed to inform the need for a biopsy. There's the American-built Prostate Cancer Prevention Trial Risk Calculator, PCPT, built on a number of clinical features which would be available, and also the European randomized study for screening for prostate cancer risk calculator built from a European population. The issue with the European one, which I'll allude to later on, is that it requires a truss prostate volume, which is not practical potentially in the Irish healthcare system, because someone would have to go and have an ultrasound, which would be done before a biopsy, but just have the ultrasound to work out the volume, then come back, make a decision, and then send them back again to have a biopsy. That's probably, so this may not be as applicable to implement. So to address this, we worked with David and his colleagues across the national rapid access clinics to gather clinical information from all of the sites that are available to us. And the first thing we did was we applied, in this case, a cohort of 2,000 men to the PCPT and the European risk calculator to see how well they performed. And they performed well, or at least they performed better than using PSA alone. So in the context of determining prostate cancer, this is an AUC, or a receiver operator curve, ROC curve, generating an AUC, which is sensitivity and specificity. And basically what you're looking for is a perfect test would give you an AUC of 1. So you're looking for something within this range. And you can see that the European calculator outperforms that of PSA or the American risk calculator in being able to predict prostate cancer. And then in the context of high-grade disease, as David was saying, there's a lot of low-grade disease. If you could rule those out initially and not even go looking for them, so again, it predicts pretty good. But as I said, the European calculator may not be that practical in an Irish healthcare system. So we then went and gathered additional data to build an Irish risk calculator and to see if we could improve on this prediction. So we gathered 4,800 men from the rapid access clinics across all the clinics in Ireland. 2,500 had prostate cancer, 2,200 had no prostate cancer. And then within the patients who had prostate cancer, we had a cohort who had high-grade disease versus low-grade disease. Now, I won't go through the statistical aspects of that. It's not relevant for this talk, but we were able to build a model and demonstrate that it actually outperforms the North American model, which would be most relevant to an Irish healthcare system. So we were able to an AUC value of 0.67, predict whether the patient had prostate cancer in a decision net benefit. This showed a net benefit. The Irish model outperformed the North American model and also was very well calibrated. So that was good in the context of predicting prostate cancer. In the context of predicting high-grade disease, again, the Irish model outperformed that of the North American model significantly, and it was also showed a benefit on decision curves, net benefit, and also in relation to highly correlated or calibrated model. So this would demonstrate that we could improve on determining who needs to go for a biopsy in the first instance. And we've been able to work out that we could reduce by about 10% the number of patients that would need to go for a biopsy in the Irish healthcare system, which would be quite significant. Now, obviously, we have a long way to improve on that. And what we've now done is working with David and the National Cancer Control Programme is to implement this risk calculator into the rapid access clinics. And as David was saying, this would help to overcome variations across the rapid access clinics in Ireland, across the north or west-east divide, and hopefully standardise the clinical decision making, at least in the initiation of determining whether a patient needs to have a biopsy or not. So for me, this is a very exciting opportunity. It's the first time where my research has actually potentially have some clinical impact, and that's the great thing about working with the clinicians, is that they see the opportunities of bringing these things into their clinical practice. And I know David is very committed to getting this rolled out across the rapid access clinics. So ultimately what we now want to do is how can we improve on that? So we've got it based on clinical information, but what are ways by which we could improve on that? Now there are a number of commercial tests out there for serum. The 4K tests can be used to help improve the prediction for the need of a biopsy, as well as the Prostate Health Index, PHI. There's a lot of studies looking at these showing that you can improve on predicting the need for a biopsy using these. I know David is working closely with the company in relation to the 4K. So as a proof of concept, we wanted to test out these tests in an Irish healthcare setting. So in addition to collecting the clinical data from the rapid access clinics, we've also had the opportunity to collect biological samples from a cohort of patients, so up to 640 patients at this stage, whereby we take a urine sample and a blood sample from these patients before they have their biopsy. Then we have access to their biopsy afterwards and determining who had cancer or who had not cancer. So we've taken in the current study, I'll demonstrate 250 of these patients applied, in that case, the PHI test to see if we can add that to the risk calculator and improve on the prediction of prostate cancer, and indeed we can. So here's the Irish model by itself, this line here, this is green, and then when we add in on top of the Irish model the PHI test, we can improve the AUC value to a significant amount in the context of predicting prostate cancer, which again shows a net benefit in relation to decision curves, and also an improvement up to 80% in relation to high-grade cancer. So we have demonstrated that the addition of, in this case, commercially available biomarkers can improve on the risk calculator. And again, we would advocate and hopefully be able to convince David and his urology colleagues in the National Cancer Control Programme that these are things that should be added in to these risk calculators. Now, ultimately, in relation to research that we're doing at the moment that I don't have time to go into, we've been working with Randox to test a number of their biomarkers in the context of this cohort, and also through a HRB study, we're looking at serum and urine biomarkers. So Antoinette Perry has developed a epigenetic signature and we're implementing that in these cohorts of patients from the rapid access clinics to determine if it would improve on the risk calculator and thus determine who needs to have a biopsy and who doesn't. The second question that I wanted to cover then was this question around indolent and aggressive. So as David was saying, if we could determine better who has indolent disease, they could go on active surveillance and try and give them the confidence to stay on active surveillance, and thus they wouldn't need to be treated and suffer all the quality of life issues associated with their treatment. So in a similar, well, there are again a number of commercially available tests out there in the market. Genomic Health have the Oncotype DX test, which is a gene signature. Genome DX has the Decipher test. Again, it's a 22 gene signature that you can assess. Myriad Genomic Laboratories have Polaris. Again, it's a signature based on cell cycle progression. But the issue about these is that you require to have a biopsy, a positive biopsy, a piece of tissue to apply the test. Now, there are challenges associated with prostate biopsy. So just to bring you back a little bit to the biology of prostate cancer, here's the prostate, here's the urethra. The majority of cancers occur within the peripheral zone of the prostate. And it is a very heterogeneous disease. So if you took a biopsy here, well, you wouldn't hit any tumor at all, and yet there are tumors here. If you took a biopsy here, well, you'd hit this tumor. But is this the indolent or is this the aggressive tumor? Maybe the lion, as we would say, the aggressive disease is lurking here and has been missed, but you've diagnosed the patient. So the issue is there is intratumoral heterogeneity and intraprostatic heterogeneity of prostate cancer. Now, I'm not advocating that we don't utilize these tests, absolutely, but what we have to do is try and develop other, maybe liquid biopsy tests, which would help to complement the tests that would be assessed based on tissue. So, as part of the Prostate Cancer Research Consortium, we established a bioresource to collect preoperatively urine and blood samples, and then at the time of surgery a tissue sample. So we have a resource whereby we could integrate liquid biopsy or biomarkers with tissue biomarkers and determine if we could improve on our prediction of indolent and aggressive disease. So in a cohort of 158 men who were divided up into indolent, significant and aggressive, we set about looking at a range of tissue-based and serum-based biomarkers across the prostate consortium. So the tissue and the blood, the proteomic analysis of 91 peptides was assessed in UCD. The glycosylation, where we assessed 50 glycosylation features, was carried out in DCU and NIBRT. The DNA methylation at the time, Antoinette was based in Trinity. So we looked at 17 methylation markers from Antoinette. And then we also looked at a range of transcriptomic and microRNA features in the tissue. And we brought all that together and analysed it. And what we were basically able to demonstrate is that of the features that were looked at, the model pulled out a number of features which were important in predicting indolent and aggressive disease. And basically what we showed is that here's the clinical marker. So it's predicting indolent and aggressive disease to about 77% accuracy. So it's the black line here. And then when you look at these omic biomarkers by themselves, they all have some prediction, some improve a little bit above the clinical model, some do not. But the most important thing is when you integrate all these markers, you could significantly improve the prediction of indolent and non-indolent or aggressive disease. So this is very exciting. It demonstrates that if you look at biomarkers in the tissue and in the serum and bring them together, probably looking at different features of the disease, you have a much more accurate way of determining who has indolent, and that could obviously inform the more appropriate treatment for these patients. The final story or caveat then is in relation to the outcome of surgery. So if a decision is to treat the patient by surgery as being the most appropriate one, unfortunately about a third of patients treated with surgery or radiation therapy will have some form of relapse or biochemical reoccurrence of their disease. So if we could determine this beforehand, we could be able to determine well, maybe surgery isn't the appropriate because maybe the disease has progressed beyond the capsule of the prostate. So this is in the context of biochemical recurrence after localized treatment before they would be put onto additional androgen ablation or chemotherapy. So again, we were from our Prostate Cancer Research Consortium Bioresource, we're able to build a cohort of 130 patients, divided up into 66 that had biochemical recurrence versus 65 that had no biochemical recurrence. And that's the value of collecting a resource and following these patients. And a great thing about working with David and his colleagues is that we can follow up these patients over time. And we built a TMA. And we took a slightly different approach here. We took a more hypothesis-driven approach. One of all the biomarkers that we've looked at in our discovery, the IGF axis represents an interesting pathway because a number of the proteins that we've identified in our discovery studies have identified the IGF axis. So we looked at in the serum using MSD ELISA's IGF-1 and IGF binding protein, which are IGF-1 obviously binds to the receptors, the IGF family receptors. And then so that happened in the serum. And then within the tissue, we looked at the insulin-like receptor. We looked at the IGF-1 receptor. We looked at PTEN, which is like the brake on the PI3 kinase pathway. So if this goes down, this brake is released and this pathway would be driven. And we looked at AKT downstream activation in the tissue. And what we demonstrated that when you look at these individually, well, PTEN does have some significant ability to pull out those patients that have early biochemical recurrence versus late biochemical recurrence. But looking at the others by themselves, there's not much. But when you started to combine these, so again, when you looked at PTEN and so a decrease in PTEN and an upregulation of insulin-like receptor, you could significantly distinguish between those patients who had early biochemical recurrence versus late. More excitingly then, the best model was when you looked at the downregulation of PTEN, upregulation of IGF-1 receptor, and an upregulation of serum levels of IGF-1. So that's this green line here. They had the worst outcome compared to high PTEN and low levels of these. So a combination of, again, serum and tissue markers was able to predict biochemical recurrence with higher accuracy. So key to what I was trying to get across, linking in with David's, is decision-making tools, and this is really where the scientific community can come in and help once we know what the key clinical questions are, and then apply the technologies that we have, whether it's omics or genomics or whatever. So building risk calculators, adding biomarkers or integrating them into these is really important. I cannot stress the importance of having access to patients and patient samples, and that's been the great thing about working with David and the PCRC and the rapid access clinics and the involvement of the clinicians, not just identifying what the clinical questions are, but having access to relevant clinical material. And I think this is really where the R&D's hospital group and all the collaborations have such a value to bring to the research that I do up in the Conway Institute, which seems an isolated environment, but yet is linked by that fundamental presence of clinical material. And then the multidisciplinary aspect. When I started this in the Mater many years ago with John Fitzpatrick, it was all just kind of biochemists and pharmacologists working together. Now 50% of my lab is bioinformaticians and statisticians, because we're generating all this data, and it's the analysis of that data that is ultimately important. So just to finish with 1 minute, the what's our research journey? So we started with the Prostate Cancer Research Consortium. DMMC, Molecular Medicine Ireland came along, and that really helped to facilitate the interaction with hospitals and clinicians through a grant led by John Crown in breast. Prostate got in there as well, and that was very, very helpful in driving some of our research. iProspect then came along at more in advanced stage disease, and then this led to a collaboration between myself and Liam with OptiPredict. David has talked about HipCore and the importance of that, and so we're kind of here at this stage. Obviously there's been lots of other individual grant successes, but in the context of a collaborative effort by the National Prostate Group, these are some of the bigger. And then through these collaborations, we've been able to link in with international groups such as TopCap, which has given us access then to groups in the US and funded through the Prostate Cancer Foundation. We had European funding, again led by Liam around FastPath. And then Movember really has been fundamentally important through the global action plans, linking us to really global funding opportunities and research groups. So we're here now. What's the future? So David and myself wanted to share this slide. We're currently working on this sort of next phase of a collaborative effort across the urology and scientific prostate cancer community. Core to this is the Prosper Clinic. We really do believe that the Prosper Clinic is not there just to support patients. Well, it's there to support patients in the context of pre and post-operative. But in doing that, we have the ability then to interact directly with patients and ask them for permission to get access to samples and to follow them up over time. And the research nurse would act as a really important focal point of that, not only giving out information around prostate cancer, gathering in information from patients, but also informing them, the patients, as to the outcome of our research. So this would be a central part of this. And the key work would be around risk stratification, longitudinal assessment of the biology of the disease, so understanding the scientific components of the disease progression. So we're very excited about hopefully getting this funded at some stage. So just to acknowledge all the people who've been involved, far too many to name individually, the funders that have been involved, and then of course the patients that we've worked very, very closely with, that David mentioned. And then just finally to say that the reason we look a bit scruffy is for a reason. Both David and myself, as many as others, are doing Movember, and that's really all about trying to raise awareness of men's health and hopefully raise a few bob along the way. But it's really about awareness. So thanks very much indeed. I'm sure David and myself would be happy to take any questions.